Good day everybody, I'm Blessed Elaine Ipla, and for today's video, I'm gonna be talking about electrolyte imbalances, specifically calcium imbalances, magnesium imbalances, and phosphorus imbalances. And lastly, we will talk about phosphorus.
Now, what is phosphorus? It is essential to the function of muscle and RBCs, the formation of ATP and 2,3-diphosphoglycerate. About 85% is located in the bones and teeth, 14% in the soft tissues, and less than 1% in the extracellular fluid. The normal total serum phosphorus levels is 2.5 to 4.5 milligrams per deciliter. What is hypophosphatemia? Hypo meaning under, low or less. Phosphat, a prefix for phosphate, and emia meaning blood. Therefore, it is termed as low phosphorus level in the blood or is less than 2.5 milligrams per deciliter. The contributing factors include refeeding after starvation, alcohol withdrawal, diabetic ketoacidosis, respiratory and metabolic alkalosis, decreased magnesium and potassium, hyperparathyroidism, vomiting, diarrhea, hyperventilation, vitamin D deficiency associated with malabsorptive disorders, burns, acid-base disorders, parenteral nutrition, and diuretic and antacid use. The pathophysiology. Here, for the increased renal losses, there would be low magnesium, low potassium, and low phosphorus, and low phosphorus may lead to hypophosphatemia. The signs and symptoms include muscle weakness, chest pain, hyperactive reflexes, paresthesias or the abnormal sensation of the skin such as tingling, bone pain and tenderness, confusion, cardiomyopathy, respiratory failure, seizures, tissue hypoxia, increased susceptibility to infection, and nystagmus or the repetitive unilateral eye movements. The complications may include arrhythmias, hemolytic anemia or the premature destruction of RBCs, respiratory failure, and muscle tissue death. Oh no. The diagnostics and laboratory procedures are the following: serum phosphorus level, PTH, and X-ray. Management. For the pharmacologic is aggressive IV phosphorus correction for patients with less than 1 mg per deciliter level and not functioning gastrointestinal tract. The possible side effects of IV administration include tetany and calcifications. Thus, the patient should be monitored closely, and it should not exceed to 10 milliequivalent per liter. And it should correct the precipitating causes and include the dietary phosphate, which include the meats, poultry, nuts, beans, and dairy products. Nursing diagnosis and management. First is risk for electrolyte imbalance, hypophosphatemia related to hyperparathyroidism. You have to monitor vital signs, heart rate, and rhythm. Monitor for signs and symptoms of respiratory failure. Monitor for signs and symptoms of hypercalcemia. And you have to encourage intake of phosphorus-rich food like meat, poultry, beans, nuts, and dairy, and administer meds as indicated. Next is anxiety related to altered health status. You have to monitor patient's mental status closely, encourage verbalization of feelings, use presence, touch, verbalization, and maintain empathetic attitude. And you have to lessen sensory stimuli by providing quiet and calm surrounding and encourage positive self-talk. Prognosis: mild hypophosphatemia usually improves if phosphate is added into the diet. Severe cases will need IV phosphate treatment. Once it has been treated, hypophosphatemia should not return. So what is hyperphosphatemia? Hyper meaning above, excess or high. Phosphat, a prefix for phosphate, and emia meaning blood. Therefore, it is termed as high phosphorus level in the blood or is greater than 4.5 milligrams per deciliter. The contributing factors include acute kidney injury and chronic kidney disease, excessive intake of phosphorus, vitamin D excess, respiratory and metabolic acidosis, hypoparathyroidism, volume depletion, leukemia or lymphoma treated with cytotoxic agents, increased tissue breakdown, and rhabdomyolysis. The pathophysiology. Here for the chronic kidney disease, we normally ingest 1000 to 1200 milligrams of phosphorus in our diet. But if there is chronic kidney disease, there is failure in excretion leading to losing the phosphorus homeostasis, which can increase the phosphorus concentration in the blood, leading to hyperphosphatemia. The signs and symptoms include symptoms of hypocalcemia, muscle weakness, hyperactive tendon reflexes, tetany, tachycardia, soft tissue calcifications in the lungs, heart, kidneys, and cornea. The diagnostics and laboratory procedures, the serum phosphate level, serum calcium level, blood urea nitrogen, and creatinine to assess renal function, parathyroid hormone level, and X-ray. Management. This is treat underlying cause, and for the pharmacologic is vitamin D preparations, which include calcitriol, calcium binding antacids, restriction of dietary phosphate, forced diuresis with a loop diuretic, volume replacement with saline, and for the surgical, it may be indicated for removal of large calcium and phosphorus deposits. Nursing diagnosis and management. First is risk for electrolyte imbalance, hyperphosphatemia related to impaired renal function secondary to kidney injury. You have to treat the underlying cause. Monitor VS, noting risks of hyperphosphatemia. Avoid phosphorus-rich foods like hard cheeses, cream, nuts, meats, whole grains, and others. You have to avoid phosphate-containing laxatives and enemas. And you have to report impending signs of hypercalcemia and monitor changes in urine output,